Hi, and welcome to this talk on multisystem inflammatory syndrome in children, which is also called MISC. I am Natasha Nakra. I'm an associate professor in the Department of Pediatrics at UC Davis. Thanks for joining today. I don't have any disclosures. So the objectives of my talk today are to review the epidemiology of MISC, to provide a hypothesis about its pathophysiology, to discuss the clinical features of MISC, to discuss the approach to treatment and some of the outcomes, and finally to describe areas of future study, since there's still so much that we don't know about this new entity. So the world was really taken by surprise with the emergence of SARS-CoV-2 infection in January of 2020, which soon spread to a worldwide pandemic. This was the original report of this novel coronavirus in the New England Journal of Medicine back in February of this year, when it seemed like it was hopefully isolated to one part of the world prior to it spreading to the United States and elsewhere. Here were some of the initial pictures of that coronavirus on electron microscopy that you can see here with the indicated arrows. Fortunately, in children, COVID-19 did not seem to cause severe disease, and so early reports really showed that children were relatively spared from COVID morbidity and mortality. This is one of the first morbidity mortality weekly reports, which is provided by the CDC. And this just described the rates of hospitalization depending on age. This was published in April based on the initial reports of COVID-19 infection back in March of 2020. And you can see that in our children, so here, this is the 0 to 4 age range, and then 5 to 17, and this is the hospitalization rates per 100,000. You could see the hospitalization rates were very low, and hospitalization rates did increase according to the age of the population. And these reports were subsequently substantiated in other parts of the world as well. So when there was a large spread through Italy, especially northern Italy, is indicated here on this map, this article came from JAMA and described that if you look at the cases by age range, this pie chart describes how it was distributed based on age. And this is just a tiny sliver here of the 0 to 18-year-olds that were affected were only at 1.2%. So you can see that it was a very small piece of the pie, and that in this table you can see that there were no deaths that were reported in that pediatric age range, so 0 to 9 or 10 to 19. And so really indicating that COVID, at least at that point in time, really did not seem to be causing much morbidity or mortality in children, which was really a relief to all of us as pediatricians. Over time, this has changed, and so we have seen that there have been increasing reports of COVID infection in children. This was a more recent morbidity and mortality weekly report published just earlier this week on September 15th. And you can see that starting back in March, there was really few infections reported in children, but especially in June and July, we saw increasing numbers of cases in the 0 to 21 year population, which is what's pictured here. And so at this point, infections in children or patients aged 0 to 21 account for about 8% of total US cases, which is in total 391,000 cases. Unfortunately, only 0.08% of US deaths, and so to date there have only been 121 pediatric deaths due to COVID. However, despite those initial reports where we all felt really good that children fortunately were being spared from morbidity and mortality, starting in late April, we started to see these reports coming out of Europe. And this was one of the first publications of this hyperinflammatory shock syndrome. This report was from the UK, and then subsequent to that, we had another report out of Italy that described an illness which seemed to resemble severe Kawasaki disease. And these occurred in regions that were heavily impacted by SARS-CoV-2, which suggested to pediatricians in Europe and then subsequently in the US that there was some sort of relationship between SARS-CoV-2 infection in the population and this inflammatory syndrome that they were subsequently seeing. And in early May, here in the United States, we also saw similar cases reported. So on the left, you can see one of the first health alerts that came out of New York City, where we know at that time there had been a large COVID outbreak, especially in April. And this report was on May 4th of this year. At that time, they described 15 cases that seemed to be compatible with this multisystem inflammatory syndrome, similar to the cases that had been described in Europe. And they said that these patients had persistent fever and features of Kawasaki disease and possibly toxic shock syndrome. And they warned that these cases may require ICU admission for cardiac and respiratory support, and that PCR for SARS-CoV-2 infection may be positive or negative. And quite soon after that, there was the first child death from this COVID-related inflammatory syndrome that was reported in the news on May 8th. And at that point, already from the 4th, when there were 15 cases, they said now there have been nearly 100 cases of patients in the U.S., pediatric patients who have been identified with this newly identified inflammatory syndrome. So it quickly became termed multisystem inflammatory syndrome in children, also abbreviated as MISC by the CDC, came up with this specific term, which is now what we've been using. And it appears to be a hyperinflammatory syndrome in children with multisystem involvement, so exactly what the name suggests, following COVID-19 infection. And pretty much these children have universally had fever and elevated inflammatory markers, but they have also had multisystem involvement. And interestingly, the most common system that appears to be involved is the GI tract, followed by cardiac, hematologic, mucocutaneous, and then respiratory. And in one series, greater than 70% actually had involvement of at least 4 systems. So that really does seem to be key to this inflammatory process. And as I have mentioned, a lot of the initial reports described it as Kawasaki-like syndrome, but other comparisons included toxic shock syndrome, as well as hemophagocytic lymphohistiocytosis, which we often call HLH. And all of these entities are marked by having significant inflammation. So the current epidemiology of MISC, at least as far as we understand it now, is that it occurs about 2 to 4 weeks after COVID infection. The cases that have been described have primarily come out of Europe, as well as South America. But interestingly, MISC was not described in China, even though we know that SARS-CoV-2 emerged there and did cause infection in children. And this has led people to theorize that maybe the virus has mutated once it traveled to Europe. And so it is only the European form of this virus that can cause MISC. And there have also been questions about genetic susceptibility and whether or not there may be certain susceptibility factors that do not exist in Chinese populations but exist in North and South America and Europe. And this is curious, partly because Kawasaki disease seems to be occur more frequently in Asian populations, and there is likely a genetic reason there. And so it seems interesting that this specific inflammatory syndrome seems to have not occurred in China, but have occurred in other parts of the world. And as of September 3rd, when I had last checked the CDC website, there have now been 792 cases confirmed nationwide and 16 deaths that have specifically been attributed to MISC. When we look at where these cases have come out of, so this again is a map from the CDC on the left, showing where the reported MISC cases are from. You can see that California, where we live, has been significantly impacted. And I compare this to a map on the right, which just shows all U.S. cases of COVID in adults and children. This is also from the CDC. And you can see that there is a lot of overlap. So the states that have tended to have more MIS-C cases have also tended to have more COVID cases. They don't perfectly overlap, but there does seem to be a correlation there. And MIS-C at this time is a nationally mandated reportable disease. This graph, which is taken from the New England Journal of Medicine article, which comes out of New York specifically, looking at children there with MIS-C, looks at the relationship between when COVID-19 cases were seen, which is indicated here in blue. And you can see on the x-axis that the majority of cases were described of acute COVID in March as well as early April. And then the reports of MIS-C seem to lag behind that, and that's pictured here in red. And that tended to occur more in later April as well as in May. And when they looked at the peak of the COVID-19 cases compared to the peak of MIS-C cases, they appeared to be about 31 days apart. And this has also been seen in other parts of the world as well, where it tends to lag, MIS-C tends to lag between COVID cases by about a month. And when they looked at the children who presented with MIS-C, about a quarter of them had had a symptomatic COVID infection. So 3/4 of them did not report having had a symptomatic COVID infection prior to then presenting with MIS-C. And the COVID infection occurred at a median of 21 days prior to hospitalization for MIS-C, but there was a range of about 10 to 31 days, which is why we now say that we think MIS-C occurs about 2 to 4 weeks after someone has had a COVID infection, whether or not that COVID infection was symptomatic or asymptomatic. 60% of the children had exposure to a person with confirmed COVID or COVID-like illness. So even if they did not have a known infection themselves, many of them did report that they had been around someone who they knew had COVID or probably had COVID. Here are some graphs which are also from the CDC, which describe more about the epidemiology of which pediatric patients are affected by MIS-C. You can see in this graph on the left that there have been cases reported in infants all the way up to age 20. However, the majority of cases have occurred in that older child, age 5 to 9, so the median age has been 8 years. And this contrasts with children with Kawasaki disease, who generally tend to be below the age of 5. In the graph on the right, we can see the proportion of patients with MIS-C that fall into different racial groups. And so you can see that actually about 3/4 have occurred in children who have been self-identified as Hispanic or Latino or non-Hispanic Black. And so we really do see that there is a predominance in these racial groups. And it's unclear why this is occurring, but there have been thoughts that racial disparities in COVID in general may be due to social factors, including more crowded living conditions or food or housing insecurity, allowing there to be more spread within certain populations. There also is a concern that household contacts of children who have developed MIS-C may be more likely to have jobs as essential workers, and thus they may be more likely to be infected with COVID-19 and then subsequently develop MIS-C. The pathophysiology of MIS-C is not yet known. It is clear that it's a hyperinflammatory state. The exact mechanism has not yet been worked out, but so far most researchers believe that it's likely part of the adaptive immune response to having had infection. So it's not related to the infection acutely itself, but rather to the body's response to the infection. Because there are so many similarities to Kawasaki disease, and because the coronaries seem to be affected, we theorize that it likely is due to a vasculitis, which is what occurs in Kawasaki disease as well. There have been many researchers that are trying to figure out the cytokine signature, so which cytokines are increased in the setting of this entity, and it looks like a lot of our pro-inflammatory cytokines are increased, such as IL-6, IL-8, and TNF-alpha, but there also are some anti-inflammatory cytokines like IL-10, which are also increased. We do know that there's a significant cardiovascular component to this entity, and so a lot of these patients have elevated troponin and BNP, and why exactly that occurs is not quite clear. So the mechanisms there have not yet been worked out. There have been some researchers that have actually compared the cytokines that are upregulated in acute COVID infection as compared to those that are upregulated in the setting of MIS-C, and they are slightly different. So this does seem to be immunologically a different syndrome than the cytokine storm that we often hear about in older adolescents and adults. And this is a diagram that was created by our chair here at UC Davis, Dr. Lakshman Rusimha. And what it does is try to provide some more insight into this hyperinflammatory state that we see in MIS-C. So here on the left, you can see stage 1 is early acute infection. And so we know in pediatric patients that tends to be asymptomatic or mildly symptomatic. And the majority of them don't go on to have this pulmonary phase that we see in adults, where they, a week or two after infection, have a significant pulmonary component leading to hospitalization and need for mechanical ventilation. So they seem to sort of skip this phase. However, they have a mild infection, which possibly maybe through a super antigen, which causes sort of this large inflammatory response, leads to activation of our macrophages and release of inflammatory cytokines that then leads to T cell activation, and T cells then lead to even further production of cytokines, leading to sort of this huge cytokine release. And because of that, we end up with a hyperimmune response. And then what we see in the patient is everything that's listed here. So ventricular dysfunction and coronary aneurysms and involvement of multiple other systems, including respiratory, neurologic, hepatic, mucocutaneous, renal, GI. And then that is what we are calling this multisystem inflammatory syndrome in children. However, we think that there likely is a genetic predisposition, and so there are certain children who have something underlying genetic, which then allows this immune response to happen if they happen to be infected with COVID. We think it's unlikely that it's direct viral injury that's resulting in what we see in MIS-C. This is another diagram which just again sort of describes the presenting clinical features of MIS-C. So if we start with fever, 100% of patients with MIS-C have been reported to have fever. Again, this is for varying amounts of time before they ultimately are hospitalized. In the New England Journal study, by the time the patient was diagnosed with MIS-C, about 90% of them have had fever for at least 4 days. So we know that similar to Kawasaki disease, they have this prolonged, persistent febrile illness. About 40% of them have some symptoms that overlap with Kawasaki disease, which include this conjunctivitis, rash, cervical lymphadenopathy, stomatitis, so involvement of the lips and mouth and tongue, extremity swelling with erythema, and then finally some of them do go on to have desquamation or skin peeling of the hands and feet. Interestingly, about 90% of them, so definitely the majority, do have GI symptoms, including nausea, vomiting, abdominal pain, diarrhea, and then a small subset of them have had increased hepatic enzymes. Universally, their labs have elevated inflammatory markers, and so they have very high SED rate, CRP, ferritin, fibrinogen. If IL-6 is checked, a lot of them will have elevated IL-6. Procalcitonin is usually elevated, the D-dimer is elevated. So all of these can be pro-inflammatory mediators, which is why they tend to be elevated. Additionally, a lot of these children will have elevated troponin and elevated BNP. And the BNP is often in the thousands or tens of thousands, so much higher than we've seen in other inflammatory syndromes. Other labs that we often see include thrombocytopenia, neutrophilia, so they tend to have a neutrophil predominance, and then lymphopenia. And finally, some of these patients do have hyponatremia, as well as evidence of acute renal insufficiency. Just to have a quick refresher on Kawasaki disease, it is the most common cause of acquired heart disease in children in the US and other developed countries. In the developing world, it still is rheumatic fever, but we rarely see that in the US now. The key to really preventing this acquired heart disease is early recognition and early treatment. So it's a medium vessel vasculitis that affects children generally between the ages of 0 to 5. And the vessels that we care about the most are the coronary arteries, because those are most likely to then lead to morbidity and mortality when those children become older. The etiology is still unknown, although we hypothesize that there may be a viral trigger, whether it's a single virus or whether there are multiple viruses that can trigger it in a genetically susceptible host. That is still unclear. There have been some reports of coronaviruses potentially being a viral trigger for Kawasaki disease, but that really has not been borne out. The clinical features include prolonged persistent fever, so at least 5 days, the diagnosis of Kawasaki disease. And then there needs to be 4 out of 5 of the clinical symptoms, which are pictured here. So we have this rash. The rash can really look like anything, except that it is not vesicular. It often resembles measles, as you can see here with this sort of diffuse truncal rash. It can be more prominent in the creases. The conjunctivitis is pictured here. So it's limbic sparing often, which means that right around the iris, there tends to be more clearing, so more peripheral erythema, and it's not purulent. So if you see purulent discharge, you should think about a bacterial cause to the conjunctivitis. There can be many different types of mucous membrane changes. This is a more extreme form where you can see that they have this cheilitis and lips are cracked and bleeding, and then this strawberry tongue appearance where the papillae are red and enlarged. You can have extremity changes, which include erythema that you can see in both of these pictures, and there can also be edema of the hands and feet. Then there can be cervical lymphadenopathy or submandibular lymphadenopathy, as shown in this picture. And then finally, what we worry about the most, which is the development of coronary artery aneurysms and peripheral arterial aneurysms. In terms of the labs seen in Kawasaki disease, they generally have an elevated SED rate and CRP. They often will have an elevated white blood cell count and a neutrophil predominance, but they rarely have lymphopenia. And then they also often have an elevated platelet count, although that's usually seen in about week 1, at the end of week 1 or beginning of week 2 of illness. So they may not have it at the time of diagnosis. So the major complication that we worry about with Kawasaki disease are coronary artery aneurysms. Prior to the known treatment that we give now, coronary artery aneurysms actually occurred in about 25% of children who had Kawasaki disease. Now that we have effective therapy, we've really reduced that down to 4%, which is pretty amazing. However, we do know that children who have coronary artery aneurysms are then at increased risk of having acute coronary syndromes, such as myocardial infarction in adulthood. There are a subset of children with Kawasaki disease, so less than 5%, who can present with a more severe presentation, which is called Kawasaki disease shock syndrome. Because they have shock physiology and multi-organ dysfunction, it's often confused with sepsis, and so these patients often end up in the unit treated for bacterial sepsis, and then when cultures are negative at 48 hours and they're still having fever, then someone realizes this is actually Kawasaki disease. Their lab values tend to be more extreme, so they tend to have bandemia. They may have thrombocytopenia rather than thrombocytosis, and they often have an even higher CRP than what we see with Kawasaki disease. Additionally, they may be more likely to have cardiac involvement, so they have higher rates of coronary artery dilation, up to 63% in one case series, and they're more likely to have ventricular dysfunction. They also have a higher prevalence of treatment failure with first-line Kawasaki disease therapy, which is generally IVIG and aspirin. So in MISC, we see that a lot of these patients, about 2/3 of them, do present with hypotension. And so that resembles that sort of subset of children with Kawasaki disease who have Kawasaki disease shock syndrome. This graphic was taken from the New England Journal article describing MISC in U.S. children and adolescents, which came out in July. And they showed that about half of children ended up needing inotropic support, and then left ventricular dysfunction was seen in about 40% of them. Fortunately, only about 4% of children ended up needing ECMO. Interestingly, 73% of these children did have an elevated BNP, and about half of them had an elevated troponin. And they reported that coronary artery aneurysms occurred in about 8% of children. In this table, I've compared the findings that we see in pediatric MIS-C to children with Kawasaki disease and then Kawasaki disease shock syndrome. So as I discussed earlier, the patients with MIS-C tend to be older, up to age 20. They may or may not have hypotension. In Kawasaki disease, we rarely see that unless they are in that subset with the shock syndrome. In all three of these entities, they can have a rash. Children with MIS-C have been reported to have neurologic symptoms. That's rare in Kawasaki disease, that they have overt neurologic symptoms, although the children often are described as having irritability. And then in Kawasaki disease shock syndrome, they're more likely to have neurologic symptoms. GI symptoms are very common in MIS-C, less common in Kawasaki disease or Kawasaki disease shock syndrome. Platelets are generally low in MIS-C, which is one lab finding that really allows us to distinguish between MIS-C and Kawasaki disease. In Kawasaki disease shock syndrome, they may be low or high. Ferritin is generally elevated in MIS-C and can be elevated in KD as well, and KD shock syndrome. And then CRP is very high in MIS-C, as well as in Kawasaki disease shock syndrome, and they tend to be higher in both of those entities as compared to KD. When we look at the cardiac involvement, troponin can really be elevated in any of these scenarios. Interestingly, though, that very high BNP seems to be more typical of MIS-C. In all of these entities, there can be coronary artery dilation or frank aneurysms. The ventricular dysfunction seems to occur more commonly in MIS-C and Kawasaki disease shock syndrome, and less commonly in Kawasaki disease itself. And then valvular regurgitation can be seen in any of these entities. So as I talked about, in MIS-C, we can see unique neurologic presentations. So some of these patients have been described as being encephalopathic. They've been described as having meningismus. There was one report of a patient with ataxia and some reports of patients with dysarthria, so difficulty speaking. And then some interesting presentations with extremity weakness and decreased reflexes. And there was one report of 4 patients in JAMA neurology who had abnormal MRIs, who actually had signal changes in the splenium of the corpus callosum, which is pictured here. So you can see that there is, where the arrow is pointing, there is a hypodensity in the corpus callosum, and this was reversible, however. So in all of these patients, over time, these corpus callosum abnormalities did resolve. Some patients have been described as having really severe abdominal pain. Some of them have even been diagnosed falsely with appendicitis and have actually undergone XLAMP and have actually been shown to have some purulent abdominal fluid. So they've had frank peritonitis. There have been many reports of mesenteric adenitis diagnosed by CT scan, as well as hepatosplenomegaly and ascites. And then finally, some patients can have pulmonary involvement, including pneumonitis and pleural effusions. When we think about COVID testing and what that may look like in our patients with MIS-C, we first start with the nasopharyngeal PCR, which is the most common way that we diagnose acute infection. What they've seen in cases of MIS-C is that it may be positive in about half of them. What's important to keep in mind is that testing can remain positive using a PCR test for weeks or months due to prolonged shedding. So even if the virus has sort of come and gone and they no longer are infectious or able to transmit the virus, the PCR can remain positive for a long time. And if you think about our kids who have had rhinovirus in the past, it seems like you check an RVP and then 1, 2, 3 weeks later, they can still have a positive RVP, even though their symptoms have resolved. It's similar to that, where our tests are so sensitive that even having a small amount of that RNA still in the nasopharynx can be picked up very easily with PCR. And so even though half of patients with MIS-C have positive PCR, a lot of them no longer have an acute infection or infectious virus present in the nasopharynx. Now, the antibody tends to be positive after about 14 to 17 days. And so here in this graph on the right, this just shows how when antibodies developed. These were in patients in China who had COVID. So you can see that the majority of them did have IgM at about 12 days after acute infection onset, and IgG at about 14 days. So if you're looking for antibodies, generally you should look in patients who have had symptoms at least 14 days previously. However, we find them to be very helpful in MIS-C. Again, that's because we think that it occurs about 2 to 4 weeks after acute COVID infection. And so in most case series, in about 75% of kids with MIS-C, they have had positive antibodies. The CDC put out a report in August, and this sort of summed up their experience with MIS-C in children across the U.S. from March to July. What they reported was that generally these patients were sick. About 2/3 of them required care in an ICU. A lot of them had cardiac dysfunction seen on echo, shock, myocarditis, coronary artery dilation or aneurysm, as well as acute kidney injury. And then, as I said previously, about 4% of patients have actually needed ECMO. Fortunately, mortality has been low, so only 10 reported deaths so far from MIS-C, which is about 2% of patients. In general, they've stayed in the hospital for about 6 days. And then, interestingly, the majority of patients have been previously healthy, and when they tried to identify an underlying medical condition, the one that was most commonly seen was obesity. In this article from the CDC, they ended up sort of recognizing that there have been 3 major patterns of children with MIS-C. And so the first, which is in this class 1, seems to really fit that definition of MIS-C the best. So these children have been older, about age 9. They've had multiple systems involved. So about half of them have had 6 or more systems involved, and all of them had cardiovascular involvement, with about 21% of them having coronary artery abnormalities. And then the majority of them have had positive serology. So 68% had positive serology, but a negative PCR, and 30% of them had positive serology as well as a positive PCR. So these patients really seem to fit best with what we think about as MIS-C. Then there was class 2, and these patients probably actually had acute COVID and maybe didn't have MIS-C. And so they really have had predominance of respiratory symptoms and less likely to have multisystem involvement. They've also been older. Interestingly, some of them did have coronary artery abnormalities, so about 16%. But interestingly, about 84% of them had a positive PCR, and they were less likely to have positive serology testing. So they really did seem to have more of an acute presentation and really didn't fit the MIS-C description as well. And then there have been a third group that have had Kawasaki-like symptoms more predominantly, and they tended to be younger. They really didn't have, again, as much cardiac involvement, although some of them did have coronary artery abnormalities, and they sort of had a mix of having positive serology and positive PCR. So it looks like there may be sort of different types of patients and different phenotypes of MIS-C that we can see, and interestingly, all of them can have coronary artery abnormalities. And so we want to make sure that we are not missing the sickest ones, but also not missing the less sick ones who may have coronary artery abnormalities. I want to talk about the first case that we saw at UC Davis here in Sacramento, which presented in July, sort of following when we really had a big peak of infections in early July. So he presented in late July. This was a 4-year-old who was previously healthy. He came in with 6 days of fever, sore throat, and abdominal pain. The fever that he had, the parents described, was daily and was persistent. They said they would give antipyretics and it would go away, but then it would just come right back. They said he had had loose stools for about 3 days. He had reported some leg pain, just seemed achy. He had a rash. He had lip changes. They had noted some bilateral conjunctivitis that was seen by the providers as well. He had started coughing on the day of admission, and they also noticed that he was peeing less than usual. And parents had both had confirmed COVID infections 3 weeks prior. He did not, but presumably was asymptomatically infected at that time. When we looked at his labs, these really clued in the emergency room providers that this may be MIS-C. So you can see that he had low platelets, he had hyponatremia. For age, his BUN and creatinine were elevated. His lymphocytes were slightly low at 1,300, and they subsequently became even lower while he was admitted. And interestingly, his CRP was very high, so 25.8. Procalcitonin was also elevated, as well as the SED rate. His fibrinogen and D-dimer were elevated. Albumin was low at 2. His LFTs were otherwise normal. His triglycerides, ferritin, were also elevated, and we know these are also markers of acute inflammation. And then his BNP was over 3,000, and his troponin was slightly elevated at 58. And when we obtained his SARS-CoV-2 testing, both his nasopharyngeal PCR was positive, as well as his IgG and IgM. And again, I really think that PCR probably reflected just some persistent RNA due to infection a few weeks prior, because his antibodies suggest that he probably had been infected at least 2 weeks prior to this presentation, and that also fits with when the rest of the family was infected a few weeks before. So when he was in the ED, he was noted to have systolic blood pressures that dropped into the 60s to 70s. They gave him a couple normal saline boluses and then quickly placed him on a norepi drip. He was admitted to our PICU. He was started on vanco and ceftriaxone due to concerns for sepsis, just for 48 hours. But Peds ID was contacted quickly because of the thought that he may have MIS-C and due to his positive testing. He was started on IVIG because of concerns of left ventricular dysfunction. He was given smaller aliquots of IVIG, so 0.5 grams per kilo initially, and then a second dose of that later that day. He was also started on high-dose steroids. He was fortunately weaned off of norepi within 24 hours. His echo, interestingly, showed what looked like possibly a left pulmonary artery thrombus. So he then underwent a CT angio to rule out pulmonary embolism, and fortunately that was negative. It was thought that there was likely just artifact on the initial echo. He was treated with Lovenox due to his elevated D-dimer prophylactically for 2 weeks. He was then transitioned to PO steroids and completed a 3-week total course. Fortunately, he was only in the hospital for 6 days, and he has subsequently followed up with cardiology and has been shown to have a normal echo, and he has also been seen by rheumatology and was doing well at that last follow-up. When we think about how we treat these children with MIS-C, unfortunately, we don't have any retrospective comparative data. So we can't look back and say, well, IVIG resulted in better outcomes or steroids resulted in better outcomes. And so really guidelines have been developed based on experts in the field, looking at other entities like Kawasaki disease, like toxic shock syndrome, like HLH, and sort of seeing what has worked in those inflammatory entities, what is safe, and then anecdotally, how have these children done having received these treatments in the small case series that are available. The American College of Rheumatology and the AAP have both put out some guidance. And here at UC Davis, we actually convened a multidisciplinary committee to sort of come up with treatment guidelines, and these included representatives from multiple pediatric specialties, as you can see listed here. So when we thought about including IVIG, there fortunately has been a lot of research done on IVIG and its anti-inflammatory properties in other entities such as Kawasaki disease. And we know that IVIG can affect the immune system and sort of dampen that overactive immune response through many different mechanisms. So one of them is that it can actually block FC receptors on macrophages, which thus leads to decreased production of inflammatory mediators such as cytokines. It can also sort of downregulate dendritic cells, so they then don't go and activate regulatory T cells, which can propagate the immune response. It can actually bind to and directly neutralize antibodies that have been produced that then attack the self. It can have other modulatory effects on a wide variety of different types of immune cells. Interestingly, in Kawasaki disease, it's well known that there is a dose response. So if you give more IVIG, it tends to be more effective at preventing coronary artery aneurysms. And to look into this a little further, this data actually dates back to the 1980s when there was this landmark article in the New England Journal of Medicine, which was a randomized multi-center trial which compared IVIG given in small aliquots over 4 days to no treatment. And what they found was that if the patients who were treated only developed coronary artery aneurysms 4% of the time, as opposed to those who were not treated who developed coronary artery aneurysms 18% of the time. They then wanted to look at whether or not it makes a difference if you give sort of the smaller dose over 4 days or a large dose all at once. And this was another landmark New England Journal article that came out in 1991. And they followed these patients out to 7 weeks. And they saw if a patient received the smaller doses over 4 days, they had coronary artery aneurysms 7% of the time, but only 4% of the time if they got that sort of large, big single dose. And that's why now the way that we treat Kawasaki disease is to give a large 2 gram per kilo infusion. And there have subsequently been other meta-analyses that have looked at many studies that have really corroborated this. So if you don't give IVIG, in this one meta-analysis, 29% of children developed aneurysms. If you gave less than 1 gram per kilo, then about 21% of them developed aneurysms. And if you gave at least 1 gram per kilo, about 10% of them developed aneurysms. And if you gave a single large dose of 2 grams per kilo, the coronary artery aneurysm rate was only 2%. So really that large single dose seems to be very effective in the setting of Kawasaki disease. There is some hesitation about exactly repeating this in our patients with MIS-C, mostly related to the fact that a lot of them do have ventricular dysfunction. And so giving them this large volume and large solute load could potentially be damaging. And so we've really left it up to our providers, at least at UC Davis, to decide whether or not they are safe to get a large dose of 2 grams per kilo or whether or not they'd want to do 1 gram per kilo or possibly divide it even further than that. There have been other biologic agents that have been discussed and have been used in patients with MIS-C. The one that we have, that I think has been discussed the most and that has been used the most widely nationwide is anakinra. Anakinra is a very safe, fortunately, IL-1 receptor antagonist. It's a biologic agent. If you look at this in sort of caricature of the inflammatory cascade on the right, you can see that macrophages really release a lot of these cytokines, including TNF, IL-1, and IL-6, which are all highly pro-inflammatory. And so the biologic agents that we've chosen to treat MIS-C really are sort of target those pro-inflammatory cytokines. Other agents that have been used include infliximab, which is also commonly used in Kawasaki disease, which blocks TNF alpha, and then finally tocilizumab, which you may have heard about for treatment of acute COVID as well. And this is an IL-6 receptor antagonist. Interestingly, for COVID, that is seen in adults who have cytokine storm, the studies have not really shown that tocilizumab decreases morbidity or mortality. So it's sort of fallen out of favor more recently. However, it still has been used in some cases of kids with MIS-C. So the American College of Rheumatology clinical guidance includes some of the statements that I've listed here. So some children with mild symptoms may only require close monitoring without immunomodulatory treatment. It's unclear whether or not IVIG is necessary to prevent coronary artery aneurysms, as we believe it's necessary in Kawasaki disease. So even children with milder presentations of Kawasaki always get IVIG because of that concern that they may go on to develop coronary artery aneurysms. And we're not sure whether or not that's true in MIS-C. They also recommended that a stepwise progression of therapies be used, and that if therapy is initiated, that it's initiated first with IVIG and glucocorticoids as sort of our first tier treatments before we move on to some of those newer biologic agents. They do mention that anakinra may be considered for treatment with MIS-C refractory to IVIG and steroids. And then finally, they say that serial lab testing and cardiac assessment should really guide our treatment response and tapering, and that some patients will require a 2 to 3 week tapering of immunomodulatory medications. This was an article that looked at MISC in children and did a systematic review of all of the case series and reports that have been published at that point. And they looked at how frequently all of these different treatment modalities had been used. So the most common over here on the left was IVIG, which was used in about 76% of cases. You can see that some of the case series that they included only children with a cardiovascular disorder, and those are indicated by the red dots. Some of them included children who met Kawasaki disease criteria, and those are indicated by the blue dots. And some of them had really broad MISC definitions, and those are indicated by the yellow dots. So you can see with IVIG that if they met criteria for Kawasaki disease, 98% of them were treated with IVIG, which makes sense because that's our approach to Kawasaki disease. About half of patients overall were treated with steroids. About half of patients required vasopressors, and then only about 18% required other immunomodulators, which included things like anakinra and infliximab. Here you can see about a quarter of patients required mechanical ventilation, and then less than 10% required ECMO. So this is our treatment algorithm as it stands currently. It has evolved even since we first had developed it back in July. And so we've divided patients into mild disease and then moderate to severe disease. Patients who have moderate to severe disease are defined as those who have needed vasoactives or inotropes, who are mechanically ventilated, who have coronary dilation or aneurysms on echo, or who have significantly decreased left ventricular function. So if they meet any of those, they're in the moderate to severe category. If they don't, then they're in the mild category. So we are proposing that all of these patients be treated with steroids. However, if it's a milder presentation, they are only on a 3-week course, which includes a taper. And if it's moderate to severe, they're on a 7-week course, which includes a very long taper. Not all of the patients are going to be treated with IVIG, and so we've come up with specific criteria. So if they meet the definition of Kawasaki disease, we feel strongly that they should be treated with IVIG. If they meet criteria for HLH, we also believe that they should be treated with IVIG, and that is per the protocol that's often used by rheumatology for patients with secondary HLH. If they otherwise do not meet the criteria for Kawasaki disease or HLH, we also believe they should be treated with IVIG if they have moderate to severe disease and cardiovascular involvement. So if they have a positive test for SARS-CoV-2, they're in the ICU, so they have moderate to severe disease, they're on vasopressors or mechanically ventilated, and then if they have some evidence of cardiovascular involvement, whatever that may be. And then finally, if they have coronary or peripheral aneurysms, we are also recommending that they get treated with IVIG because essentially they would meet the definition of Kawasaki disease by having aneurysms detected. When we look at our experience to date here at UC Davis, we have had 5 patients who have confirmed as having MISC. There have been some other patients that have not quite met the definition for various reasons. So only 5 have actually been treated according to this pathway. They have all been treated with steroids, and 4 of them were treated with IVIG as well. There was only 1 who had refractory disease and ultimately needed treatment with anakinra. In general, they have been in the hospital for about 6 days with a range of 5 to 15 days. There have been 4 patients that have needed vasopressor support. None of the patients have actually had any kind of coronary artery involvement, including dilation or frank aneurysm. And then only 2 have had mild LV dysfunction, and none have had moderate to severe LV dysfunction. And those who have followed up and had repeat echoes with cardiology have not developed coronary artery aneurysms after hospitalization. This is our current algorithm as to how these patients are evaluated and sort of triaged. We provided this to our outpatient providers as well as our ED providers. And so you can see that we have sort of divided it into three categories depending on how severe their illness is and how long they've had fever. So we do recognize that there are some patients who will have had fever for a short amount of time but present more acutely with multi-system involvement, and they're ill appearing in shock. And we do feel like those patients should be evaluated for MISC in addition to sepsis and other etiologies of shock. If they have fever for at least 3 days, but not yet 5 days, but they have other signs of multi-system involvement, so maybe they have a rash and GI symptoms and vomiting, and there's no clear reason for that, we also believe that they should be evaluated for MISC. And then finally, if they have fever for greater than or equal to 5 days without any clear etiology, we believe they should also have labs checked to evaluate for MISC and Kawasaki disease. We do recognize that with the way that our algorithm stands now, outpatient and ED providers may be evaluating a lot of children who just have viral infections. And so we do anticipate that we will revise these guidelines, especially as the winter respiratory season approaches. We are recommending at this time that the patients that meet these criteria do get labs done, which include a CBC, CMP, sed rate, CRP, urinalysis, blood culture, and if they're ill appearing, a VBG and procalcitonin are also recommended. If they have evidence of inflammation, so they have a CRP greater than 5 or a sed rate greater than 40, and they have at least one more of the following: lymphopenia, thrombocytopenia, hypoalbuminemia, hyponatremia, then they should get a secondary evaluation. And the secondary evaluation that we're currently recommending includes troponin, BNP, ferritin, triglycerides, LDH, creatine kinase, coagulation panel, and then testing for SARS-CoV-2, both with the nasopharyngeal PCR as well as with antibodies. We also recommend that they should get an EKG as well as an echocardiogram, and then finally imaging as clinically indicated, which includes a chest x-ray and abdominal ultrasound. Again, if they have symptoms that would suggest that we should look in those specific anatomic locations. If they have elevated troponin, BNP, ferritin, a very elevated D-dimer, or significant hyponatremia, we are recommending admission. And depending on their clinical illness severity, that may be either to the PICU or the PEDS ward. If their secondary labs are reassuring, we're really leaving it up to the provider in the ER or the outpatient provider to decide whether or not admission is necessary. If they are sent home, we are recommending that they have close follow-up, especially if fevers persist, with representation to the ER or to the PCP for a repeat lab evaluation to see if things are evolving over time if the fevers persist. In terms of our future directions, there is still a lot more that I think we are going to learn, a lot more research that is currently being undertaken to really understand why MISC is occurring, what's the pathogenesis, what risk factors exist in certain pediatric patients, why do they develop it and not others. We also want to understand more what the long-term sequelae are. Are these patients at risk for having acute coronary syndrome similar to children with Kawasaki disease? What's the risk if we don't treat them with IVIG up front that they will have coronary artery problems subsequent to that? We also want to be able to evaluate the efficacy of different treatments. So does IVIG work better for MISC? Do steroids? Do other anti-inflammatory treatments? And what's their impact on the morbidity and mortality from MISC? And then finally, something that I think will be really interesting to see is what is the impact of vaccine on MISC? Our hope is that vaccine will decrease MISC and that children will be vaccinated, less likely to develop COVID, and thus less likely to develop MISC. However, there is a small concern, if vaccine engenders antibody responses and immune responses similar to what happens after COVID, could some patients actually develop MISC from the vaccine itself? So far, this has not been reported, but we will have to sort of wait and see as trials progress and the vaccine is introduced in the population to see if that's a possibility. So a lot more that we're currently looking into, and that is hopefully in the pipeline soon. So thank you so much for listening. I hope you enjoyed this presentation, and thank you.